Hello. Good morning, everyone. We will review today the role of stem cell transplantation in lymphomas. Slide number 4, please. After a brief introduction on the types of stem cell transplantation, we will review separately each role in the most representative histologic subtypes of lymphomas: diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, and peripheral T-cell lymphomas. Next slide, please. Autologous stem cell transplantation is a procedure that allows the administration of high-dose chemotherapy. Autologous stem cells are harvested from the patient and cryopreserved. Later on, patient is admitted to the hospital, central line is placed, and high-dose disease-specific chemotherapy is administered. Stem cells are later infused intravenously through a central line. Those stem cells migrate and harbor in the bone marrow to regenerate the hematopoietic tissue. In around 14 days, bone marrow is regenerated and peripheral counts are recovered. The whole point of the transplant procedure and the stem cell infusion is to rescue the marrow from the chemotherapy toxicity and therefore allows the administration of high-dose chemo. This procedure makes sense, therefore, in chemosensitive disease such as lymphoma. Slide number 6. The first part of the procedure of allogeneic stem cell transplantation is not very different from the autologous transplant. Patient receives chemotherapy, then stem cells from an HLA-compatible healthy donor are infused through the central line. Around 14 days later, the new bone marrow generates functional peripheral cells from the donor origin. These new peripheral cells include the cells from the immune system that can recognize the tissues from the receptor as foreign and induce graft versus host disease. This is one of the major limitations of allogeneic stem cell transplant. However, the new immune system from the donor can also induce adoptive immunotherapy against the tumor, the so-called graft versus tumor, or in this case, graft versus lymphoma effect. GVL effect is what makes the difference in this procedure and enhances the anti-tumor activity. Next slide. Slide number 7. To place stem cell transplant in the therapeutic algorithm of diffuse large B-cell lymphoma, we need to remember the natural history of the disease. Diffuse large B-cell lymphoma has an estimated survival of around 10 years. Survival at 10 years of 30 to 40%, with a median survival of 4 to 5 years. It is highly chemosensitive disease, with response to therapy of around 60 to 75%, but relapses are common of around 33%. International Prognostic Index can predict the risk of relapse. Slide number 8. Since 1995, when the PARMA trial reported a 46% 5-year event-free survival for patients who received salvage autologous hematopoietic stem cell transplant, against 12% for those receiving chemotherapy alone, the standard of care for patients with relapsed diffuse large B-cell lymphoma has been salvage therapy followed by autologous transplant. Next slide. What should we expect from the salvage chemotherapy followed by autologous transplant in the rituximab era? Much of the information can be withdrawn from the CORAL trial that compare rituximab, ifosfamide, etoposide, and carboplatin, the R-ICE regimen, with rituximab, dexamethasone, cytarabine, and cisplatin, the R-DHAB regimen, for patients with relapsed and primary refractory diffuse large B-cell lymphoma. The overall response rate was 63% and 38% for patients achieving complete remission. The 3-year event-free survival rate was 31%, with no difference between the two arms. For patients who underwent autologous transplant, the 3-year progression-free survival was 53%. No difference was observed for patients who achieved CR or PR before autologous transplant. However, the dropout rate in the CORAL study was 50%, mainly due to tumor progression. Despite salvage therapy, only approximately half of patients actually proceeded to transplant, a figure that identifies one of the key limitations to current salvage practice. Slide number 10, please. The factors that affected the response significantly were primary refractory or early relapse before 12 months, secondary age-adjusted IP, and prior exposure to rituximab. 3-year event-free survival rates in this trial were 21%, 20%, and 18% for those who had been treated with previous rituximab at relapse within 12 months, or those with secondary age-adjusted IP scores of 2 to 3, respectively, versus 47, 45, and 40% for those without these characteristics. Further analysis of these patients identified the activated B-cell type and germinal center B-cell type with overexpression of MYC as pathologically unfavorable disease. Next slide. Slide number 12. At the time of workup of the relapsed refractory diffuse large B-cell lymphoma, it is evident from the CORAL trial that patients with short remission duration, high second-line age-adjusted IP, unfavorable phenotypes are unlikely to do well with standard salvage therapy and autologous transplant with beam-type conditioning regimens. These account for approximately 70% of patients who are transplant eligible for relapsed and refractory diffuse large B-cell lymphoma. Therefore, current second-line or salvage therapy seems inadequate in the rituximab-CHOP era. Studies evaluating immunotherapy post-transplantation, including allotransplantation, new conditioning regimens with radioimmunotherapy, or other combinations of chemotherapy for salvage treatment are needed. The most common transplant regimen used in this setting is the combination of PCNU, etoposide, cytarabine, and melphalan, so-called BEAM regimen. There have been many efforts to improve on the efficacy of this treatment, but no large comparative studies documented a superiority of one regimen over another. Next slide, slide number 13. TBI-containing regimens have demonstrated an increased early toxicity such as mucositis, as well as the late toxicities including myelodysplasia, cataracts, and dry mouth. These side effects, in conjunction with a general lack of additional long-term benefit after TBI-based regimens, have resulted in a general reduction in the use of radiation-containing regimens for autologous transplant for lymphomas in recent years. Next slide, slide number 14. The Tocilizumab radioimmunotherapy was added to BEAM regimen in a recent prospective randomized clinical trial from the Clinical Trial Network trials and showed no significant improvement in overall outcome compared to BEAM plus rituximab. Slide number 15. The addition of Zevalin has shown interesting phase 2 data. One phase 3 trial of 43 patients comparing Zevalin plus BEAM with BEAM indicated a significant overall survival advantage, 91% versus 62% overall survival at 2 years, for the Zevalin plus BEAM group. In another report from the City of Hope, Zevalin was administered along with BEAM and compared with TBI etoposide cyclophosphamide regimen used at the institution as a historical comparison. The Zevalin BEAM regimen had substantially less toxicity and a superior overall outcomes compared with TBI regimen. Slide number 16. The role of allogeneic stem cell transplantation. It is tempting to look at the outcomes of allogeneic stem cell transplant regimens for patients with high-risk disease, such as those identified in the CORAL study. Unlike autologous transplant, allogeneic stem cell transplant generates a GBL effect that reduces the likelihood of disease relapse after transplantation. It needs to be pointed out that previous studies suggested a very modest GBL effect, if any, in aggressive histologic subtypes. We can see in the figure a slight reduction of the relapse rate after allogeneic stem cell transplant, but no impact of T-cell depletion or syngeneic transplant. Standard myeloablative conditioning regimens were associated with unacceptable treatment-related deaths and age limitations. The advent of reduced intensity conditioning regimens has renewed interest in allo stem cell transplant, which reduces non-relapse mortality while maintaining the GBL effect, and therefore allows the treatment of elderly patients and or patients with comorbidities. Slide number 17. Currently, the major role of reduced intensity conditioning allogeneic stem cell transplant is in the treatment of patients who have failed an autograft or in whom an autograft is not possible. In the European Group of Bone Marrow Transplantation report, 101 patients were evaluated and found to have a 42% relapse-free and a 54% overall survival at 3 years. The two main factors affecting outcome were relapses before 12 months after autologous transplant and the quality of response before transplant. With a better definition of the prognostic factors and the poor results obtained with high-dose therapy and autologous transplant in early relapse, high secondary age-adjusted IP, and the histologic subtype, we can now discuss whether, in a case of a response, these patients should be transplanted directly with reduced intensity conditioning allo or autologous transplant or treated with a tandem approach of autologous followed by allo. Nevertheless, it should be pointed out again that reduced intensity conditioning allo should not be proposed to refractory patients. The evaluation of such an approach remains an unsolved challenge. Finally, for the role of stem cell transplant in diffuse large B-cell lymphoma, we can see here the EPNT recommendations. Autologous stem cell transplant is still considered the standard therapy for patients with chemosensitive relapse of diffuse large B-cell lymphoma. The role of autologous transplant as first-line therapy in diffuse large B-cell lymphoma patients with intermediate high or high international prognostic index at diagnosis is still controversial. Autologous transplant is not an option for refractory patients with diffuse large B-cell lymphoma. New and innovative approaches should be sought for these patients. Patients with early relapse or resistance to first-line therapy and those failing multiple treatment modalities, including autologous transplant, might be considered candidates for allogeneic transplant, although the role of such a strategy is not defined. Only prospective clinical trials, including a sufficient number of patients, will be able to adequately address this point.
Okay, thank you. I want to welcome the audience. Thank you, Dr. Sanz. We do have some questions regarding the patient selection for patients with diffuse large B-cell lymphoma going on to transplantation. Is there a role for first-line transplantation in patients with high-risk EP or patients with SEMIC-positive diffuse large B-cell lymphomas?
That's certainly a point of discussion. IP clearly defines survival risk and a relapse risk, and there's a high risk group patient with either an unfavorable histologic subtype or with high risk IPI, young patient that might benefit from high dose therapy first line. However, those negative prognostic factors also affect the results of autologous transplant. And although those prognostic factors can predict the risk of relapse, you can never predict in an individual patient. I would say that transplant high-risk patients with autologous transplant first-line young patients is feasible and might be beneficial. However, the standard today is to transplant after for salvage therapy, so after relapse, or transplant those patients with primary refractory disease that are chemosensitive at time of transplantation.
Another question is the best moment for recollection of the stem cells, because when we think on salvage therapy and high-dose RSC, and we're always worried about not having enough stem cells. Is there a recommendation on when to do it?
Recommendation is to harvest and collect stem cells as soon as possible. So probably try to collect after first or second cycle of salvage therapy, when possible, and if the bone marrow is not infiltrated. But try to collect as soon as possible.
Okay. And can you mention the toxicity profile of immunotherapy as a conditioning regimen?
Immunotherapy, radioimmunoconjugates, you mean, or immunotherapy like monoclonal antibodies? Radioimmunotherapy. Immunoconjugates are seem to be not toxic, do not add toxicity to the conditioning regimen. The only thing is that administration of these drugs needs specific timing, and the programming of the transplant gets a bit more difficult. And patients need to receive radioimmunoconjugates in certain conditions at a certain point in time before the transplant. Doesn't allow you to play with your times and admit the patient whenever possible. You need to calculate well the times. So it's a bit more difficult to plan, but it's certainly not toxic.
Okay, and one more thing, we usually have a discussion about chemosensitive disease. You know, if patients are with a good partial response, should they benefit of more chemotherapy before going on to transplantation? Is negative a prognostic factor for transplantation?
Good question. Common sense tells me that the better response you have at time of transplant, the best results you would get. But adding more chemotherapy in certain patients will not improve responses and will add toxicity. Most studies of autologous transplant have shown that the best response at time of transplant is a marker for further outcomes. But Pharma trial and Coral trial did not find a difference for those patients achieving PR or CR at time of transplant. So it's difficult to make a recommendation here, but if you have a chemosensitive patient for which you're not having toxicities, I guess the best idea is to give him few cycles to achieve best response. For those patients where you see chemosensitivity, but you don't think you're going to achieve complete remission, and this patient is having toxicity, so probably the wiser thing to do is to transplant at that point.
Okay, thank you. You can go on.
Okay, slide number 20. Role of stem cell transplant in follicular lymphoma. Again, I'd like to review the natural history of the disease before getting the transplant issue. Remember, this is an indolent lymphoma with a median survival of 6 to 10 years, a constant relapse rate of 5 to 10% per year with no plateau. It is therefore considered an uncurable disease. Subsequent relapses tend to have shorter responses. Slide number 21. 3 large randomized trials from Europe before the availability of rituximab have compared the efficacy of autologous transplant compared with conventional therapy with interferon maintenance as consolidation. In 2 of the 3 trials, progression-free survival was significantly higher in the transplant arm, but there was no difference in overall survival between the transplant and conventional therapy arms across all 3 trials. Most concerning was the significantly increased incidence of therapy-related malignancies seen in the transplant arms that negated the advantage conferred by improved progression-free survival. Subsequently, the Italian group of bone marrow transplant, the GITMO group, conducted the first randomized trial in the rituximab era comparing autologous transplant with standard therapy in high-risk follicular lymphoma patients. Again, an advantage in progression-free survival did not translate into improved overall survival. Patients in the conventional chemotherapy arm who relapsed were crossed over to the transplant arm, which resulted in a 68% 3-year event-free survival after a median follow-up of 30 months. Based on the results of the above 4 trials, autologous transplant as consolidation therapy in first complete remission is not recommended routinely. However, because the majority of these data originated from the pre-rituximab era, longer follow-up is necessary in patients who receive rituximab during initial therapy and in the peri-transplantation period to truly determine the efficacy of this in this specific follicular lymphoma patient population. Slide number 22. In contrast to patients in first remission, autologous transplant has a more definite role in patients with relapsed disease. Both prospective and retrospective studies report high response rates with 5 years progression-free survival ranging from 40 to 50%. With regard to prognostic factors, patients who are not heavily pretreated, patients with chemosensitive disease, and those having a lower follicular lymphoma international prognostic index score at the time of autologous transplant had improved overall survival. The EBMT conducted the only randomized study that addressed prospectively the role of autologous transplant compared with standard therapy in relapsed follicular lymphoma patients. A total of 140 follicular lymphoma patients with chemosensitive disease after salvage chemotherapy were randomized to receive further conventional therapy, autologous with PERT graft, or autologous with an unpaired graft. There was a significant reduction in hazard rates of both progression-free survival and overall survival between the chemotherapy-only patients and the autologous transplant patients. The 4-year overall survival was 46% for the chemotherapy arm, 71% for the unpaired arm, and 77% for the paired arm. Unfortunately, this trial closed early due to slow accrual and was also conducted in the pre-rituximab era, which limits the relevance of these findings. Slide number 23. Based on the current literature, it is easier to determine who is not an ideal patient for autologous rather than ascertain who is the optimal candidate. Relapsed follicular lymphoma patients who should not be offered autologous include those who are chemo-resistant, have had 3 or greater prior regimens, have a poor performance status, and those greater than 70 years of age. Otherwise, patients who are beyond first complete remission but chemosensitive, do not have bone marrow involvement, and have a good performance status, are excellent candidates for autologous transplant. However, for patients with limited stage at relapse, thoughtful consideration should include offering only radiotherapy and/or conventional treatment. Regarding conditioning regimens, the most frequently used conditioning regimen for follicular lymphoma undergoing autologous transplant are chemotherapy-based. TBI is associated with a significantly higher risk of therapy-related myelodysplasia and acute leukemia. The anti-CD20 radioimmunoconjugates are currently not routinely offered due to their high cost and the complex logistics, and do not appear to increase efficacy compared to chemotherapy alone regimens. Slide number 24. Naturally, the next question is, when should allotransplant be offered instead of autologous? Allogeneic transplant is the only known curative modality for patients with follicular lymphoma. The existence of the GBL effect mediated by donor T cells is supported by the observation of lower relapse rates compared with autologous, as shown in these 2 figures. In addition, For patients with indolent lymphoma who relapse after allogeneic stem cell transplant, disease regression has been reported after withdrawal of immunosuppression medications and after donor lymphocyte infusions. Slide number 25. In the earlier studies of allogeneic stem cell transplant for follicular lymphoma patients, myeloablative regimens were primarily offered and yielded lower relapse rates compared with recipients of autologous transplant. However, the high non-relapse mortality associated with the ablative regimens mitigated the benefit of a lower relapse risk Reduced intensity conditioning regimens have been used increasingly in follicular lymphoma patients, and results have shown durable remissions and less non-relapse mortality compared with myeloablative regimens. Because evidence of both retrospective and prospective trials has revealed that chemosensitivity rather than conditioning intensity is the most reliable predictor of outcome, the absolute indications of an ablative regimen are nearly obsolete. Therefore, a myeloablative regimen should not be recommended for a follicular lymphoma patient outside a clinical trial. Prospective trials of follicular lymphoma undergoing reduced intensity conditioning allo included patients who had failed a prior autologous transplant and patients above 60 years of age and used a fludarabine-based preparative regimen. With median follow-up ranging from 3 to 10 years, the disease-free survival and event-free survival range from 43 to 75%, and overall survival range from 52 and 81%. Chemosensitivity at the time of transplant was a consistent predictor of outcome. The trial from the MD Anderson group represents a prospective trial with the longest follow-up that reported an 11-year event-free survival and overall survival of 72 and 78% respectively, with only 3 relapses observed. Slide number 26. To conclude with the role of transplant in follicular lymphoma, we have the EBMT recommendations. Patients with follicular lymphoma are normally not considered candidates for autologous transplant as first-line therapy. Autologous transplant remains the standard approach for early relapsing patients with follicular lymphoma. Results of autologous transplant in truly refractory patients are poor. These patients should probably be offered alternative approaches. Allogeneic stem cell transplant has mainly been performed in patients with multiple relapses, including a prior autologous transplant. Reduced intensity conditioning was used in most cases. From the information derived from retrospective registry analysis and from single-center prospective phase 2 trials, as well as multi-center prospective analysis, the transplant-related mortality and relapse rates are low, and the long-term outcome seems favorable. The impact of the use of alternative transplant is under evaluation. Prospective studies need to be performed. Slide number 27. We will review the role of transplant in mantle cell lymphoma. The aggressive and systemic nature of mantle cell lymphoma argues in favor of implementing aggressive therapeutic strategies in the frontline setting. The only randomized trial suggesting an advantage for early transplant, was reported by Freiling et al. On behalf of the European Mantle Cell Lymphoma Network. In that study, 122 patients were randomized after responding to CHOP-like regimen to either maintenance with interferon 3 times a week or intensification with high-dose chemotherapy and autologous transplant. Patients in the transplant arm had a better progression-free survival when compared with interferon patients. However, overall survival was similar at 3 years, 83 versus 77%. A recent study by the Nordic group showed excellent long-term results and suggested a possible change in the natural history of the disease. This Nordic mantle cell lymphoma 2 trial treated 160 consecutive mantle cell lymphoma patients with a dose-intensified chemoimmunotherapy combination using R-CHOP alternating with rituximab cytarabine. Responding patients underwent high-dose therapy followed by transplantation using stem cells paired in vivo with rituximab. Overall response and complete remissions were 96 and 44% respectively. The 6-year overall survival, event-free survival, and progression-free survival were 70, 66, and 56% respectively, with no relapses occurring after 5 years, suggesting a possible plateau. The lack of relapse after 5 years is intriguing and suggests for the first time a possible plateau in mantle cell lymphoma, arguing in favor of this approach. Slide number 28. The largest analysis on the benefit of transplant in mantle cell lymphoma was reported in a study of the European Bone Marrow Transplant Registries. Outcome was reported on 195 patients enrolled with a median follow-up of 3.9 years. The 2-year overall survival was 76% and at 5 years 50%, with progression-free survival of 55 and 33% at these time points. Disease status at transplant was the most significant factor affecting survival. Patients with chemosensitive disease, but not in complete remission, were 3 times more likely to die than patients transplanted in first complete remission. This large analysis showed that patients transplanted in first complete remission fared better than those transplanted in subsequent remission, thus arguing for early transplant. Slide number 29, the role of allogeneic in first-line mantle cell lymphoma. Adoptive immunotherapy in the form of allogeneic transplant is frequently considered for patients with relapsed chemosensitive mantle cell lymphoma. No prospective randomized data assessing the relative risks and benefits of upfront allo in mantle cell lymphoma versus auto or conventional induction therapies alone are available. However, non-randomized registry data showed a significantly higher non-relapse mortality with upfront allografting and no benefit on survival. This data caution against the routine use of allo in mantle cell lymphoma in first remission. Early allo may, however, be considered in selected mantle cell lymphoma cases with primary refractory disease based on the CIBMTR research data suggesting that about 20 to 25% of these cases could be disease-free 3 years following allografting, despite initial chemorefractory disease. Next slide. Results suggest that allo transplant may be of limited benefit in patients with relapsed disease who have been extensively treated previously. However, the European Group of Bone Marrow Transplantation presented their experience with weak allo. The initial report showed a prohibitively high treatment-related mortality of 46% at 1 year and poor 2-year overall survival of only 13%. Results of mantle cell lymphoma seemed worse than for other histological subtypes, mainly due to disease progression going against the strong GBL effect in this disease. Slide number 31. To conclude, recommendations of EBMTs for mantle cell lymphoma. Despite the lack of a survival benefit in randomized studies, high-dose chemotherapy and autologous transplant is recommended in fit patients with chemosensitive disease as first-line therapy. This is based on the observation from phase 2 studies that show better outcome compared with patients that did not undergo such procedure, from the Nordic study suggesting a plateau, and from a randomized trial showing improved progression-free survival compared with no autologous transplant. In addition, the registry retrospective analysis suggested that transplant in complete remission 1 might be superior to transplant in complete remission 2 and beyond. Suitable patients with relapsed disease after an adequate first-line therapy could be considered candidates for an allogeneic stem cell transplant, despite the fact that data are only available from a very small phase 2 clinical trials and respective registry analysis. Therefore, allotransplant should be considered an experimental procedure reserved for fit, good performance status patients who have failed previous autologous transplant and who have a donor. Next slide. Slide number 33, to finish with the subtype, the role of transplant in peripheral T-cell lymphomas. T-cell non-Hodgkin lymphomas are a heterogeneous group of lymphomas. Standard treatments such as combination chemotherapy with CHOP or CHOP plus etoposide chemotherapy are less effective for T-cell lymphomas than for B-cell lymphomas, with the possible exception of ALK-positive anaplastic cell lymphoma. In general, the overall survival rate for patients with T-cell non-Hodgkin lymphoma ranges from 18 to 62%, based on the prognostic index of peripheral T-cell lymphomas, which is worse than the overall survival rate for patients with B-cell lymphomas. Slide 34. There have been no randomized peripheral T-cell lymphoma restricted clinical trials evaluating autologous transplant in first complete remission to standard chemotherapy alone. However, there have been a number of prospective phase 2 retrospective and randomized comparative group studies of autologous that have included all types of high-risk lymphomas, including peripheral T-cell lymphomas. An important finding from the prospective studies is that not all patients can achieve a complete remission or partial remission to frontline chemotherapy, and thus go forward with high-dose therapy and autologous. The percentage of patients who can proceed to autologous varies from 40 to 73%. Those who are able to proceed to transplant have outcomes similar to those seen after frontline therapy for B-cell lymphomas. With modern conditioning regimens, autologous transplant is safe, with treatment-related mortalities below 5%. After autologous, the complete remission rates vary between 59 and 81%, and overall survival rates vary from 73 at 3 years to 39 at 4 years. Prognostic factors for better outcomes have included low prognostic index scores at transplant, LDH levels, and able to achieve complete remission before transplant. Slide number 35. A number of retrospective, single institution, and registry studies have been published for the role of autologous transplant in relapsed disease. In general, the reported results in most studies is that relapsed and refractory settings are comparable with those seen with autologous transplant for relapsed B-cell lymphoma if transplanted with chemosensitive disease. Patients who have refractory disease and peripheral T-cell lymphoma or cutaneous T-cell lymphoma subtype do not seem to benefit from this approach. What about allogeneic transplant? Allogenic transplantation has also been studied in patients with relapsed and refractory T-cell lymphomas. Like most studies of autologous transplant, most studies of allogenic are also of a retrospective nature, have a small number of patients, and include a variety of conditioning regimens, including both myeloablative and reduced intensity. Corradini et al. Conducted a phase 2 study with reduced intensity allo in 17 patients with relapsed or refractory peripheral T-cell lymphoma. The estimated 3-year overall and progression-free survival was 81 and 74% respectively. The non-relapse mortality at 2 years was considered acceptable at only 6%. Donor lymphocyte infusion induced a response in 2 patients whose disease was progressing after allograft, further supporting the existence of a graft versus lymphoma effect, which has also been reported by other investigators. A retrospective registry analysis from EBMT reported on the results of allogenic transplant in 45 patients with uncured immunoblastic T-cell lymphomas. The cumulative incidence of non-relapse mortality was 25% at 12 months. Relapse rate was estimated at 20% at 3 years and was lower in patients developing chronic graft versus host disease. The progression-free survival and overall survival rates were 53 and 64%, and were significantly better in chemosensitive disease patients. Slide number 37. To conclude with recommendations with EBMT for peripheral T-cell lymphomas. Peripheral T-cell lymphomas usually have a very poor prognosis. Results exist from phase 2 trials and multi-center retrospective analysis suggesting a positive effect of autologous transplant. These patients should be, however, included in prospective clinical trials. Phase 2 prospective trials and retrospective studies indicate the potential benefit of reduced intensity conditioning allos in patients with peripheral T-cell lymphomas in second response. There is almost no information of allo stem cell transplant as early consolidation therapy for patients with peripheral T-cell lymphoma.
Okay, thank you very much. We don't have much time, but I'd like to discuss a topic you haven't mentioned and the role of transplant in follicular patients with transformed to diffuse large B-cell lymphoma. Do you think that's an indication for transplant in first line, or is it autologous transplantation, or in young patients should we consider allogeneic transplantation?
I think transformed follicular lymphoma patients should probably be treated as high-risk diffuse large B-cell lymphoma patients. Therefore, high-dose therapy and stem cell transplant can be offered as first line in young, fit patients. The role of allogenic is not that clear. A possibility is to offer the chemotherapy of an autologous followed by the allogenicity of a big allo in a tandem approach. That is a possibility that needs to be investigated.
Okay, just to round it up, is there any patient with lymphoma, with non-Hodgkin lymphoma, in which you will offer allogeneic in first complete remission?
Difficult. I guess here the best candidates would be those diseases that are not very chemosensitive, so choose alloreactivity instead of chemotherapy and autologous transplant, and very sensitive to alloreactivity. And I think the best lymphoma subtype for this approach would be peripheral T-cell lymphoma. They are highly sensitive to immunotherapy and not very sensitive to chemotherapy. And of course choose this subset of high-risk peripheral T-cell lymphomas, young, fit, with a donor? Maybe that's so true. Generally, the answer would be no.
Okay, well, thank you. We had a great time listening to your review of the literature. Thank you very much, and I want to thank the audience for being with us, and goodbye.
Bye.